Hello, everyone, and welcome to today's webinar, Respiratory Management for Severe COVID-19 Patients. My name is Stefano Chen. I am the Clinical Manager of Respiratory Care, Philips SRC APAC. Philips invited 4 speakers from China and Italy who have been managing severe COVID-19 patients in the front line. Together with 4 international NIV experts Q&A panelists to share their best practices, different approaches, and many other useful information to help clinicians in other countries to manage and fight the COVID-19 pandemic. Now, I would like to introduce our chairperson and the first speaker of today's webinar, Professor Chen Rongchang from China. Professor Chen will be presenting overview of respiratory management for severe COVID-19 patients in China. Professor Chen is the director of Shenzhen Institute of Respiratory Disease and the chairman of the 10th Chinese Thoracic Society. He has been treating 16 severe COVID-19 patients with his colleagues in Guangzhou. Our second speaker is Professor Stefano Nava from Italy. He will be presenting overviews of respiratory management for severe COVID-19 patients in Italy. Professor Nava is the chief of the Respiratory and Critical Care Unit, Santo Sola Hospital in Bologna. Professor Nava is the editorial board and the editor of many national and international journals. He was the chairman of several other professional organizations. Professor Nava has been managing severe COVID-19 patients since the outbreak in Italy 3 weeks ago. Our third speaker is Professor Xie Lixin from China. He will be presenting NIV management for severe COVID-19 patients, a case report from Beijing. Professor Xie is the director of Respiratory and Critical Care Medicine, General Hospital of PLA. Professor Xie is the chair of Critical Care Group, Chinese Thoracic Society, and also the Secretary General of China Professional Committee on Infectious Disease. He has been managing more than 80 severe COVID-19 patients in Beijing. Our fourth speaker is Professor Pinhua from China. Professor Pang will share a severe COVID-19 case report from Wuhan. Professor Pang is the director of Respiratory and Critical Care Medicine, Xiangya Hospital. He is the vice chair of Respiratory Critical Care Group, Chinese Thoracic Society. He is also a chair or vice chair of several professional organizations. Professor Pan has been managing around 100 severe COVID-19 patients in Wuhan since January. At this point, I would like to turn the presentation over to our chairperson, Professor Chen Rongchang.
Good evening for my colleague in China, and probably good morning for professors in the UK, United Kingdom, and Europe. Now I will take the initiative to discuss a little bit about new coronavirus, our experience in China in terms of ventilatory support. So perhaps everyone is busy with to deal with the new infectious disease, new coronavirus called COVID-19, and based on the most recent published data, this data mainly from Wuhan, and majority or almost half of the patients develop respiratory failure, and 31% develop ARDS, and higher percentage of the patient demand ventilatory support, including high flow nasal cannula, oxygen therapy, and NIV, and invasive ventilation, and even ECMOs. So there's a lot of debate on how best use of this ventilatory support. There's 2 guidelines in China. One is the guideline for the general diagnosis and management of COVID-19 by the National Health Commission of China, and they simply stated ventilation support, including oxygen therapy, high flow nasal cannula, NIV, intubation, and all this. Never stated in what situation we should use which one. And another guideline is the guideline for management of severe patients, and it's stated that based on the PF ratios between the 200 to 300 and oxygen therapy, maybe HFNC can be used, and the PF ratio between 150 to 200, a trial of NIV for 1 or 2 hours to see the response was recommended. And in case of PF ratio less than 150, intubation is suggested. There's several questions, important questions related to use NIV. The first is the difference and similarity between the HFNC and NIV. Indication and contraindication for NIV. Application procedure and response evaluations in terms of what kind of mode and parameter settings. An indication for switching from NIV to intubation, and safety concern about the medical staff who implant NIV. This the question is around the society. There's some discussion in China, and there's no direct evidence for patients with COVID-19. So we take take use of some old knowledge or experience in SARS, because also it's a coronavirus infectious disease. And that's a cohort. 39 cases met criteria for ARDS, made to the Guangzhou Institute of Health at that period. And majority of them show initial good response to the NIV. And the setup of intubation criteria is the PF ratio less than 120. And the actual intubation rate is 33%. In other terms, 67 of these cases can manage with NIV without intubation. And for these patient met the criteria for ARDS, the mortality is 8%. And the overall mortality for the whole Guangzhou for SARS is 3.6%, the lowest in the world, I suppose. And this picture is taken in 2003 during the SARS outbreak, the real picture we take at that time. And see the response after 1 or 2 hours to NIV. Majority of the patients have a response in terms of the reduction of breathing rate and improvement in oxygen saturations. And we have done an analysis showing for the success and failure group, the main difference is the baseline PF ratios. A very low baseline PF ratio is a predictor for the failure. What determined to switch intubation for this group, in terms severe dyspnea failed to improve after NIV, we will try to intubate. We try every effort to avoid severe desaturation before the intubations. So that's the reason, in case you use NIV, good tolerance, and sort of breath improve and oxygen improve, to keep on. In case sort of breath persistent, will intubate. There's also some experience in dealing with the viral pneumonia, H1N1. This is typical cases confirmed cases of H1N1 and with the transfer to our hospital with SpO2 90 on 3 liters of oxygen. And this case is simply because we have also used the antiviral therapy and also other medications. CPAP was used continuous. We emphasize continuous use for 3 days until the illness improved, and then later on intermittent use, and the patient was discharged home later on. So the improvement of NIV, the PF ratio is up to 300. So we do also have some experience in using NIV in other influenza-related ARDS. And this is the brief summary of the case admitted to Guangzhou Institute of Respiratory Health starting from the January 16 to March 12. And this is a real picture we use. Nasal NIV with the filter, and it's a real pictures and for that. And the center was responsible for the care of critical ill cases. Totally, we admitted 16 cases, a small number, because in Guangzhou we have totally more than 340 cases. And one is in critical ill condition, and one in severe ill conditions. And 12 of them already intubated when they transfer, and even 5 with VV ECMO to transfer to our centers, and 4 cases with oxygen, not intubated. So all these 4 cases receive NIV at the moment. I will show you the data about these 4 cases. At the moment, low mortality so far, 6 already intubated and discharged from the ICU, some go back home, some in the general ward, and 4 cases receive NIV and all recovered without intubations. So at the moment, and only 7 still in the ICU, 9 discharged from the ICU. So I don't think that the mortality is as high as those reported in the literature. And look at the typical cases of this one is middle-aged man confirmed as PCR and typical chest X-ray. And when transferred to our institute, the PF ratio is 128, and after 2 hours on NIV, it's up to almost 200, and the breathing frequency decreased, and also the patient is well tolerated the NIV. We emphasize that NIV should be used continuously without stopping. We against to stop using NIV for eating. So majority of the patient will put a gas tube for feeding rather than stopping the NIV in any conditions. So the mode we use is BiPAP. FiO2 is 0.5, and IPAS between 14 to 16, EPAS 6. And the patient improved a week later, and then intermittent use, and then later on discharge home and discharge to general ward and discharge home. So look at the 4 cases together. The baseline PF ratios ranging from 128 to 287, and the 3 of the 4 are in a critical illness status. And we use CPAP or BiPAP, and this is the setting of the NIV and the pressure, inspiratory pressure and expiratory pressure between 5 to 6. And we also the PF ratio improve after 1 to 2 hours on NIV compared with the baseline. So all these patients recover quite well. Compare the strategy in Guangzhou with the overall outcome from the other cities. So at the moment, the outcome in Guangzhou cohorts is best compared in terms of the mortality and things. And there's some percentage of the patients they receive long-invasive ventilations. But this situation vary between the hospitals and depending on the doctors in charge of the patients. And I got this picture from my colleague who are working in Wuhan now. He has been working there for more than months. And there's a lot of discussion on NIV use in our societies. And at the moment, there's no standard protocol. Many medical staff from different specialties involved the management of the cases. Maybe Nathan preferred Pan. He now still in Wuhan, can tell me more about this. And some doctors, they never have experience in dealing with patients with respiratory disease. They like an ENT doctor or things, they have to involve in the care of the patient. FFNC is first choice and have good compliance, easy to use, and they continue to use until the desaturation and severe respiratory distress, even with FiO2 up to 70, or even they use 100% oxygen. And at this point, and the severe short of breath and desaturation develop, they switch to NIV. At this point, the poor response in majority of cases, the successful rate is really low. Even the compliance with NIV is poor. Many patients try to use NIV, improve a little bit, and then stop using it and switch to oxygen therapy or HFNC, and then deteriorate again. So this is a picture. They use the NIV in the ward rather than in ICU. And this is the picture of the chest X-ray. I think this is very severe cases and need to be ready to intubate. But I discussed with my colleague, and because the ICU bed is full, and they have to work in manage patient in the general ward rather than ICU. So there's some also concern for the transmission infection of medical staff, and the Respiratory Care Committee of Chinese Society just established consensus. We recommend to use the filter to decrease the transmission, and also we recommend the personal protection of the medical staff. In this situation, in Guangzhou, in the whole Guangdong province, at the moment, no single medical staff was infected. At the moment, because we are well prepared, the personal protection is well implemented. So I don't think implementation of NIV will increase the risk of infection of medical staff. So there's many questions actually rather than answer. At the moment, no standard protocol and no consensus on the efficacy and safety of NIV in COVID-19. Many questions demand concern and investigation. Proper selection between HFNC and NIV, criteria from stretching from HFNC to NIV, should we keep until you have to titrate more than 50% or even 70% of the FiO2, or we need a criteria for that. Application procedure and response evaluation, indication to switch to intubation, and safety concern about the medical staff. And that's what I take the initiative for this, and thanks for my colleague from Guangzhou Institute of Respiratory Health. And we have a good discussion before my presentation with Nanshan Zhong, Yimin Li, is a specialist of ICU, the head of ICU, Xiaoxin Liu. She has taken so many taking care of so many patients, and Jimin Lin helped me to prepare the slide. And that's my illustration of the talk, and I hope following, and we have more specialists that have Professor Nava will give a presentation, and so his expertise in this area. So, Professor Nava.
Thank you. That was a really useful and interesting talk for all of us. Your experience is really leading us, because we were hit by an hurricane like 4 weeks ago. Totally unexpected, I would say. First of all, I didn't, unfortunately, been for the first time home since 3 weeks. I didn't have time to prepare set of slides. I will show you only two small flow chart that we prepare as the Italian Association of Respiratory Disorder Physician. But before showing you and discussing with you what we proposed, I want to try to differentiate our experience compared to the Chinese experience. Well, as I said, everything started from two different clusters, both of them located in north part of Italy. And we learned later, we are learning now, that the two different clusters, they probably had different kind of severity. The one in the city called Codogno was extremely aggressive. It has been shown that the RO ratio was much above 2.5. That means 3 or 4. That means that one single patient could infect 4 or 5 patients. The other cluster, that it was on the east part of North Italy, was probably less severe, since the RO ratio was about 2. So we got two different kind of pictures. That, since the area were not very far from each other, now is spreading all the north and part of the center of Italy. Well, we face two different problems that what described in China. The first one is age. At the beginning, we only faced, I would say, relative old patients with a lot of comorbidities. On average, we admitted patients over 75 in the first 3 weeks of epidemics. Most of them, they were affected by hypertension, obesity, or diabetes, as described in the large bunch of literature. In the last week, more or less, last 10 days, the picture totally changed. Now we admit much, much younger patients. We got in our unit a 30 years old man that was perfectly fit before. And we see more and more people on their 40s, 50s. We still see like old people, but the epidemiology really changed in the last 7-10 days. I don't know the reason why, but it's something that you need to take in your mind. A completely epidemiological changes. So this was the first peculiarity, I would say, of Italy compared to what I can understood from China. The second is the phenotype of the patients empirically change a little bit. At the beginning, being older, the patient, and with a lot of comorbidities, they worsening was a little bit slow. Like you got 2 or 3 or 4 days to understand if the patient was a responder or not responder to either treatment, oxygen, NIV, CPAP. Until 10 days ago, we have time to understand if the patient was a failure of a success. Now, more recently, I don't know if Annalisa had shared the same, my same view, we face a different phenotype. People, they are worsening very, very, very fast. Like you see these people in the unit on oxygen, reading the newspaper, and 3, 4, 5 hours later, they got a tube. So it's a totally different picture than what we have more or less 4 weeks ago. It looks like nowadays people are worsening very fast. In 24 hours, they come to the hospitals, they report short of breath, they have oxygen saturation that is, I would say, on average 94, 95, and then they can rapidly switch to severe respiratory failure. I don't know why, but this is what we have. The third and most important for this teleconference dedicated to the treatment is what we are facing differently from China. In Europe, we have the lowest percentage of critical care beds. We have like 10 times less ICU beds and high dependency unit beds than in the United States of America. So this drove all our therapeutical choices, because our ICU beds were very rapidly saturated. So we need to think out of the box, apply all the treatment outside the ICU and the high dependency unit, and even out of respiratory wards. What we are doing now, we are treating the large majority of the patient everywhere in the hospitals, in the emergency room, in the surgical room, in the orthopedic room, in gastroenterology room, in otorhinolaryngology, everywhere in the hospital. There are hospitals that are totally dedicated to COVID-19. Let's the case of my hospital. My hospital has around, altogether, like 60 ICU beds out of 1,250 beds. So what happened is that these 60 beds were rapidly saturated. So we need to treat all of the people coming into the hospital in the medical world. And this made a huge, huge, huge difference in the treatment. And also in end-of-life decision. Now, let's come back to the topic of this webinar. But without not knowing the whole picture, it would be impossible for you to understand our choices. Okay, perfect. This is very basic, but it's what we do not in all the hospitals, because it depends where you live. Some hospitals did not have yet the burden. Others are totally full. So this is only what we wrote as Italian Association of Respiratory Disease Doctors. So when a patient is coming to the emergency room, we give a green line to patient coming to the hospital with a saturation higher than 94 and the respiratory rate lower than 20, sorry. Basically what we do, we perform a specimen to assess if a patient is positive or negative, and we send the patient home. So the green line, we send the patient directly at home. Yellow means that a patient comes to the hospital with the oxygen saturation lower than 94, but higher obviously than 90, but the respiratory rate is higher than 20, and saturation responds quite well with oxygen between 10 and 15 liters per minute. With a face mask, no venturi, just a quick check. And if they can rise at a saturation over 94, we admit to whatever you can find the spot. Neurology department, whatever. We got special wings of the hospital dedicated for COVID patients, and doctors totally unaware of any critical care issue, like, as I said, neurologists, surgical doctors, whatever, are taking care of these patients. This is just how to enter in the circuit of the hospital. Orange, in the emergency room, if the patient has a saturation lower than 94, respiratory rate higher than 20, and they have a poor response to oxygen, well, in the emergency room, they try either CPAP with the helmet, then we come back later why the helmet, or non-invasive ventilation, but we always with a FiO2 lower than 50. If they respond, they go to what we call medium intensity wings. So they are treated by usually internists, like gastroenterologists or endocrinologists, people dealing with disease like diabetes, hypertension, cardiologists, and so forth. Last, if the patient on the emergency room admission has a saturation lower than 94, respiratory rate of 20, and they do not respond to a trial of CPAP, of NIV, they are sent directly to a critical care bed, whatever it is. And if there is space, we intubate them. Otherwise, we can't. Now, so to come back to sum up what I said so far. At admission, what we decide, there are 4 different tracks. Green, we send the patient home. Yellow, they respond only to oxygen and they are sent to low intensity. Orange is response only to CPAP or NIV and we send to intermediate level. Red, when they do not respond in terms of PF. Then you need to face that this patient, everywhere they are if they deteriorate, they need a support. So this is what we suggest in Italy, at least in the large majority. First choice is not NIV, is CPAP. And the first choice is with the helmet without humidification. And the CPAP is set at the pressure between 10 and 12. There is no evidence base here. It's only matter of practicality. As I said before, whatever you are, you need to make things extremely simple. And people, they're not used to deal with mechanical ventilation. They need simple things. So they don't need to plug anything in the electricity. Nurses should be trained. We didn't have time to explain what is a expiratory valve, vented and not vented mask, vented and not vented circuit. So the easiest thing is to put the helmet. Helmet is safe because you have 2 filters here and here. So the risk of contamination probably is lower. The only problem is when you remove the helmet from the head of a patient, because the helmet becomes a reservoir of viruses. So first choice recommended is CPAP with the helmet. The second choice, only for ease of use, is CPAP with a mask. Then, third choice has been considered NIV before intubation. Is the third choice for different reasons. First, because as I said, most of these patients are ventilated outside a protected environment. That means that people are not trained to use NIV. So in our unit, we use NIV, but we are expert, okay? We know how to use it. We know how to set the vented and not vented mask. But if you go where the large majority of patients are, in the moderate and low intensity, you cannot afford to teach in one day how NIV works. So the first choice, it was a full face mask. Well, in my unit, we prefer to use the helmet with a ventilator. And I have to say, not because I'm here, that the Philips ventilators, not only the Philips, but the Philips ventilator with the helmet works well, because you know that with the helmet, you need to set some different parameters compared to the total face mask. So the Philips vents is working fine with the helmet. in matter of pressurization and so forth. So last comment that I want to make, in the ideal world, you should ventilate it with NIV people in a negative pressure environment. Unfortunately, we, in our hospital, out of 1,240 beds, we only have 25 negative pressure rooms. So they ran it out immediately. So what we decide to do, we decide to put patients in a very large rooms, like a surgical operating room, with big windows, and we don't care if it's cold or not. We periodically open all the windows. This was also recommended by the WHO to add a change of the air. You may say, well, this is not evidence-based medicine, this is primitive, whatever, but when you face an emergency, you need to face an emergency. So I finish, but I want to say one more things. Here I want, even no Italian is working except Annalisa, I want to express all my feeling, all my gratitude, all my admiration to all the staff working in this day in the hospital. They are great, they are marvelous. From the cleaning lady to the chief of the department. We are facing something that was totally unpredicted. We are facing something that I think is beyond our possibility, but we do it. And I therefore really want here to face all the staff in the Italian hospital that we are facing a disaster. And I say we all love you. Thank you.
Okay, thank you, Professor Nava, for your wonderful presentation. Actually, we will keep the question and answer at the end after the full presentation. So next, I would like to invite Professor Xie from Beijing to give a presentation on your experience on this.
Thank you, Professor Chen. I listened to Professor Nava's presentation. I agree with Professor Nava's idea, but based on our experience, just want to discuss some questions about COVID-19 patients. I am Dr. Xie Lixin from Chinese Imperial General Hospital from Beijing. I want to discuss the difference between the different COVID-19 people. To our experience, our hospital during the past 2 months, there were about 80 COVID-19 patients admitted to our hospital, and we have also team working in Wuhan city to guide the local hospital treatment. Based on experience, we've also found that for aged, especially for over 80 years old patients, during the first onsite, especially for first 10 days of onsite, this aged patients have high risk for death. But if this patient have go on first 10 to 15 days, the following days, this aged patient were somewhat safe compared to 50 to 65 patient. Just for me, the same middle-aged patient are more severe. Similarly, you can see the picture. This article published in Cell Hospital and Microbe. To our experience, we found that for young-aged people, especially below 30-aged people, the general conditions are good. Mostly belong to mild or moderate stage, because they have strong defense against this virus. But for old-aged patient, on the first week of onsite, this aged patient, especially for over 80 years old, they are easier to getting worse and for death. Most induced not for COVID-19. For the risk death is most for their comorbidities, such as heart disease and chronic lung disease or chronic renal disease. But for our experience, we found that especially for our received severe patient, these patients who are among 50 to 65, they're middle-aged patients, this patient especially admitted to hospital for 2 weeks later, these patients are more getting severe and more have high risk to receive invasive ventilation, even receive the ECMO therapy. For this patient, mostly the one with very low absolute lymphocyte counts and constant long-time virus positive. So this is also experience. I go on to report my case for receiving non-invasive ventilation. This patient was female, 68 years old. She presented to febrile outpatient department of our hospital on February 27 with cough, sputum, protraction, chest distress for 2 weeks, gradually getting worse with high fever for 2 days. She was diagnosed with COVID-19 by qPCR test for throat swab specimen. She had no history of traveling to Wuhan and close contact with COVID-19 patients. The BMI of the patients was 33, and the temperature was 38.1, and the pulse rate was 107. Respiratory rate was 227, and after receiving arterial blood gas, the PF ratio was 256 millimeter of mercury. After receiving chest CT, it shows that diffusive infiltration of right lung and the left lower lung of this patient. From February 28 to March 4, this patient received high flow nasal cannula oxygen therapy, but the general condition gradually getting worse. On March 4, the partial PF ratio was only 120. Roxo score was only 2.73. It meant high flow nasal cannula failure. So since March 4, this patient received non-invasive ventilation. After 2 hours of non-invasive ventilation, we use V60 ventilator, non-invasive ventilator. The PF ratio is up to 168 millimeter of mercury. Based on the patient condition, we think that the oxygenation did not continuously improve after 1 day of non-invasive therapy under high level of non-invasive management. The IPAP is 22 and the EPAP was 12. FiO2 was 50%. The patient was difficult to cough up sputum. And our team had a good experience on prone position on the NIV treatment. Prone position is those that can increase aeration in dorsal lung region, reduce intrapulmonary shunt, improve ventilation perfusion ratio, and promote sputum expectoration. Airway clearance therapy while vibration expectorator for this patient was necessary. So from March 5, the patient received prone position and airway clearance therapy. Dramatically, after 2 hours of prone position, the arterial blood gas result showed that the PF ratio up to 220 millimeter of mercury. Based on the good result from since March 5 to March 8, this patient received prone position at least 6 hours a day. This is a result of blood gas March 8. the PF ratio was up to 260 millimeter mercury. So the patient changed to receive high FFNC therapy, and the general condition was getting better. In conclusion, I agree to Professor Chen and Professor Nava's opinion. Based on experience, the criteria of our team is if the patient, the PF ratio below 300 millimeter of mercury, high flow nasal cannula or nasal oxygen therapy is recommended. If the PF ratio below 200 millimeter of mercury, NIV with ICU NIV ventilator is recommended. If the PF ratio below 150 millimeter of mercury, close monitoring is necessary. If the does not improve after 2 hours of NIV, especially for patients with de novo acute respiratory failure, invasive mechanical ventilation should be selected. Thank you.
Thanks for Professor's wonderful presentation and good experience. It's very special cases with prompt precision management. I will keep the Q&A later on, and now I would like to invite Professor Han to give his presentations.
Thank you, Professor Chen. And hello, everyone. I'm Professor Pan Pinhua from Pinhua Hospital, Central Southern University. After the outbreak of until now, we have treated over 100 patients in the ICU in Xie Hospital, Wuhan. It's my honor to share my case about one patient of COVID-19 pneumonia. That patient is a 61 years old man, was admitted to our hospital on February 9, 2020 because of cough, fever, and short of breath for 16 days. Her present manifestation is dry cough and fever with a temperature of 38 degrees. And the CT scan show viral pneumonia, and the patient was diagnosed COVID-19 by RT-PCR. On February 6, the patient developed a short of breath, which was obvious after activity of the resistance and oxygen therapy. It could be relieved. The pulse history have no special. The physical examination is temperature is 38 degrees. The pulse is 128, and the respiratory rate is 30 per minute. And the BP is normal. SpO2 is 8% after 1 room air, and can improve to 95% at a treatment of 10 liter minute oxygen while mask. That patient was admitted to diagnosis is COVID-19 and severe type. At the first step, we gave the mask oxygen therapy. However, NIV is the backup rating 15, and the FiO2 is 60%. And we use the double A with AB field, both limbs. And at the same time, we have given antiviral treatment and lopinavir and ritonavir, and we give liberine. On February 13, the PF is become more worse, so we give intubation and invasive mechanical ventilation. We use the AC model. FiO2 is 8%, PEP is 10%, 10 centimeter. The blood gas analysis is pH 7.23, PCO2 is high, 71, and the PO2 is 77, and the lactate is 2 point. However, the patient is not become but improve. So on March 1, we tracheostomy performed and started MV T-stomy. At the same time, we have adjusted the treatment and the anti-infection. We use the meropenem and the nizazolid and the anti-viral therapy. We use the Abidol, and we give the IV medication. At the same time, we have used the glucocorticoid treatment, methylprednisolone, 40 milligram, cover 12 hours, and we have given 5 days. That table shows all the examination. The white blood cell at the first is low, but at the most time, the WC is nearly at normal, but the lymphocyte is very low all the time, and the CRP is in high. We have regarded the inflammatory cytokine, interleukin 6 is high. That is the liver function and the BNP is normal, but it is rarely normal. Arterial blood gas analysis at first we use the NIV. However, the PCO2 is become higher. At first, the PCO2 is 71. After we give the invasive mechanical ventilation, the PCO2 is decreased to normal. The beginning, when we use the invasive mechanical ventilation, the PCO2 improve well. However, when the February 24, the patients become worse, and the PCO2 is begin to increase. At the 26, the PCO2 is increased to 86, and the PO2 is become worse. And between we to use the invasive mechanical ventilation, we give the prone position and treatment. That is the chest radiograph. The first is February 22. The middle is February 29. The 29, the chest radiograph is northern wheel. However, the chest radiograph is deteriorated on the March 6. Between the invasive mechanical ventilation, we have do some fibroscopy examination and the deep mass, and we have to do the ultrasound assessment. The ultrasound assessment shows many B lines at the lung, and the cardiac function is normal. The results show the RT-PCR at the February 10. The RT-PCR is positive. However, the RT-PCR is negative on the February 27 and February 29. This is the summary of the treatment measures. Antiviral therapy is Abidol, Pinhua, and Nitanavi, and Ribavirin, and antibacterial therapy, and buxofloxacin, meropenem, linezolid, and at the end we have given the TCC, and this is the IV management February 10 to February 13, and the invasive mechanical ventilation were into tracheotomy and the invasive tracheostomy, and on March 2, CRT treatment was performed. That picture shows the trend of temperature change. At most time, the temperature is high. That's blue. There were no significant improvement in oxygenation. The urine volume decreased gradually. The patient's circulation system deteriorated gradually. The patient have a persistently increase in activity. On March 7, the patient developed severe hypoxia due to respiratory and circulatory failure. The patient expired. So thank you for your attention.
Thank you to all the doctors, and thank you for watching part 1 of our 2-part series. If you would like to watch part 2, please click on the link below. And if you would like more information regarding Philips and Philips respiratory care products, click on the second link below.